So let's say you're taking care of a 35-year-old man. He's been ejected from a car crash. He is altered. He's agitated. He's hypoxic. You have decided to take his airway. You're worried about his ability to control it because of his altered mental status. Let's say his oxygen saturation is 86% on room air. Heart rate's around 112. Blood pressure is, let's say, 150 over 84. How are you going to intubate him? Are you going to raw dog it just using butane alone? No medications? Are you going to do a ketamine-only intubation in this patient who is already altered and agitated? Are you going to do RSI, rapid sequence intubation, where you push some ketamine, push some rock, intubate? Or are you going to do a delayed sequence intubation, where you push some ketamine, you wait a little bit, then push your rock, then you intubate? What's it going to be, boy? Yes or no? You going to do DSI? You going to do RSI? Ketamine only? What's it going to be? Well, I'll tell you what. We have a paper that can help us inform this decision. Stick around. We'll go over the details.
What is a lighthouse? It is a tower with a bright light at the top, located at an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome back to another episode of the EMS Lighthouse Project podcast, where we shine the bright light of science on the darkness of current EMS clinical practice. So that scenario we started, the 35-year-old kicked out of a vehicle, traumatic brain injury, agitated, hypoxic, altered mental status. That is a really common setting for a patient with a difficult airway, both anatomically and physiologically. So how is it difficult? Well, anatomically, even though he's relatively young, and let's assume that he's not, say, 2 Texas units big, we know that he's likely to have a bunch of crap in his airway. He's going to have a soiled airway. That crud can come from blood, from the trauma itself. He bit his tongue, he bit his lips. Who knows where the blood's coming from, but it's everywhere. We also know that he's going to have this partially ruminated mix of tacos and beer in there, and you're going to have to go all Jim DeCanto on it and get that stuff out before you take the airway. That is hard, difficult anatomically. We also know it's difficult physiologically because he is hypoxic already. Now, what we know about hypoxia is that the more hypoxic you are, the more rapidly you become even more hypoxic. Our friend, the oxyhemoglobin dissociation curve, or as I like to think about it, the oxygen desaturation curve, says that if you're really well saturated, you can go a really long time apneic without getting more desaturated. But once you're on that steep end of the curve, baby, you move just a little bit and it drops rapidly. You can go from 86 to 66 in about 20 seconds. That is the danger part of that curve. So that is a physiologically difficult airway. We also know that hypoxia causes badness. In patients with traumatic brain injury, it increases the odds of death, even with one episode of hypoxia. This is what we've learned from our friends in Arizona with the EPIC trial. We also know that that is the main cause of cardiac arrest during the peri-intubation period. Hypoxia, when it gets to be profound, causes bradycardia, which causes hemodynamic collapse and cardiac arrest. These are bad. Now, finally, we know that he is agitated. He's agitated and hypoxic, whether he's agitated from the hypoxia or from the 2 beers that he had or from the TBI. We don't know, and honestly, we don't care. But what we do know is this is a patient that needs to be pre-oxygenated, and all of the things that we do to pre-oxygenate him, he is going to interfere with. Agitation makes it hard to properly prepare a patient for safe intubation. So this is a patient that is just custom built for DSI, delayed sequence intubation. So the paper we have to talk about today is one I'm really excited about. The reason I'm so excited about it is this is a randomized controlled trial of DSI versus RSI, and it is a great confirmation of the findings that I had in a paper that I did about this when we implemented it in Williamson County. What I'm going to do is talk about this paper and compare and contrast it to the findings that I had in Wilco. So the citation for this paper is Dr. Bandyopadhyay and his colleagues, Dr. Kumar et al., and the title is Peri-Intubation Hypoxia After Delayed versus Rapid Sequence Intubation in Critically Injured Patients on Arrival to Trauma Triage, a randomized controlled trial. This is hot off the presses, published May 2023 in Anesthesia and Analgesia. All right, so let's talk about this paper. So first off, this was a randomized controlled trial. We like that. That's good. Let's run the PICO question. The population was adult patients with trauma arriving at a large academic emergency department in India who were felt to need intubation. Now, there were some important exclusions here that I'm going to come back to in just a second. The intervention was DSI. The comparator was RSI, and the outcome was peri-intubation hypoxia that they defined as any hypoxia between the time they began pre-oxygenating and 1 minute after intubation. So let's go back and talk about those exclusions. And I think these are really important. Number one, they excluded any patient with an anticipated difficult airway. This included patients with severe burns or mandibular fractures, patients that they felt like were going to have basically the typical difficult airway stuff. Now, I, as an emergency physician, am a little hurt about one of the things they said, but they said if the patient was going to be intubated by an emergency medicine resident, that was also going to be a difficult airway, and they excluded the patient. So if it wasn't an EM resident who was doing the intubation, well, it was a second-year anesthesia resident. They were the ones doing the intubation. Another anesthesiologist was pushing the drugs in a DSI fashion or an RSI fashion as determined by random assignment. So what were those protocols? Well, DSI said we are going to give 0.5 milligrams per kilogram of ketamine in repeated boluses as needed to achieve dissociation. And they described dissociation as, quote, calm and spontaneously breathing. I'm going to skip over that because I'm not sure calm is the same thing as unconscious and unaware of being paralyzed. I'm going to leave that for another podcast, but that is their definition. Now, when they gave that ketamine, they reached full dissociation. They began pre-oxygenating, and they did it with just a regular face mask at 10 liters per minute of oxygen. No positive pressure ventilation, no NIPPV, no BVM, no apneic oxygenation, just face mask at 10 liters. Once they got the SAT to 94 or above for 3 minutes, they pushed 1.5 milligrams per kilogram of succinylcholine and then intubated with direct laryngoscopy. DL only here. Now, the RSI, they did the 1.5 well, first they tried to pre-oxygenate, again with the face mask at 10 liters as best they could for 3 minutes. Then they pushed 1.5 of ketamine and followed it up with 1.5 per kilo of sucks, and they intubated again with DL. Now, one thing to notice about this is they were not using end-tidal oxygen to measure pre-oxygenation like they might do in the OR. In the ER there, they didn't have it, much like almost all of us don't have it. But they also didn't have end-tidal CO2, and therefore their confirmation of tube placement was with breath sounds and epigastric sounds and misting in the tube only. That kind of scares me, but that was the standard. Unfortunately, that's not really the point of this paper, but just reached out and got my attention. Now, one other thing I want to talk about with their methods, because I've had this ongoing discussion with a good friend of mine, they defined what a laryngoscopy attempt meant. And it meant the blade passes the teeth. Doesn't matter what you do with it, once it passes the teeth, that is an attempt. That is the correct definition of an attempt. I really wish we would all get on board with what the literature clearly defines an attempt as. Now I'm going to go over really quickly some of their statistical analysis. Number one, they used SPSS, gross. Number two, they did a sample size calculation based on the assumption that 57% of trauma patients will be hypoxic, and DSI should have an absolute increased benefit of avoiding hypoxia of 20%. Using that, they calculated about 100 patients in each group. So that's what they tried to enroll, and as it turns out, they nailed it. That's exactly what they got. So let's take a look at their results. So it turns out at baseline, the patients were really pretty similar, like you would expect from randomization. Same age, same GCS, all of the things. And as it turns out, their initial oxygen saturation before any type of pre-oxygenation was also about the same. They measured oxygen saturation in 1 minute increments throughout the process, and what they found is statistically higher oxygen saturations after pre-oxygenation and every minute thereafter. So I said statistically different. However, boy, the numbers, there was not a whole lot of hypoxia after, well, certainly within the DSI group, but the differences were like 92 to 93 oxygen saturations at these points. So statistically, but not necessarily clinically relevant. So overall, their primary outcome, peri-intubation hypoxia, was substantially lower in the DSI group. Specifically, it was 35% in the RSI group and 8% in the DSI group. That is an absolute difference of 27%. That is statistically significant, both in terms of the p-value that they calculated and the confidence interval that I calculated, just because I like 95% confidence intervals better. That was 16 to 38%. So bottom line, DSI made a huge difference in the proportion of peri-intubation hypoxia. I think that's really important. Now, they said that they did a multivariable logistic regression controlling for something, because their methods doesn't explain what they were controlling for. But what they found is the odds ratio for peri-intubation hypoxia with RSI versus DSI was 6.82. That is a 582% increased odds of peri-intubation hypoxia with RSI versus DSI. Statistically significant, as you would imagine, with odds ratios that high. The confidence interval was 2.82 all the way up to 16.5. Definitely higher. Now, they also noted that first pass success was higher in the DSI group versus the RSI group. They found first pass success of 69% in the RSI group and 83% in the DSI group. That is an absolute difference of 14%, and that is anywhere from 2% up to 26% on the confidence interval, also statistically significant. Now, one other thing they did is they said, regardless of what group you were in, DSI or RSI, they looked at the airway injuries based on whether it was a first pass or not, and there was a statistically and clinically increased rate of injuries with RSI. So it's 31% in the RSI group versus 8.5% in the DSI group. Much, much higher. Now, with any paper, there are some limitations. I think the biggest limitation of this paper was those exclusions. I think this is a limitation because the patients that are most likely to benefit from DSI are those patients with a predicted difficult airway or an unanticipated difficult airway. The reason we are doing DSI is to maximize pre-oxygenation, and that buys us as much time as possible. When you have a difficult airway, you go in, you're having trouble visualizing or you're having trouble passing the tube, you need as much time as you can to successfully intubate the patient without having to back out, bag the patient up, which takes more time and also increases the likelihood of aspiration, regurgitation, and aspiration. So we want to make this as safe as possible. So those exclusions, excluding the difficult airway patients, I think those are just the patients who need this. And by excluding them, I think we are underestimating the size of the benefit. Now, particularly if you look at their consort diagram, what you will find is that 11% of patients with DSI had an unanticipated difficult airway versus 19% with RSI. These are the patients that they randomized and then excluded. So more patients with RSI were excluded. And again, that group, the ones that were going to have the difficult airway, would have benefited more, in my opinion. Therefore, I think this benefit that we're seeing is actually an underestimation. Now, some other limitations of this paper, the way they approached this is different than the way I think most of us approach either an RSI or a DSI. Number one, we're probably more likely to just go with what we're reasonably comfortable as a dissociative dose of ketamine to begin with, typically around 1 to 2 milligrams per kilogram. We are also likely to use video laryngoscopy. We're more likely to elevate the head of the bed, put the patient in an intersternal notch position. We're more likely to pre-oxygenate in a way that is going to do a better job of it. That is using non-invasive positive pressure ventilation, things like BiPAP or CPAP, or at least a non-rebreather, even though the bag and the non-invasive positive pressure, much better than a non-rebreather. Non-rebreather is better than a face mask they used. They also didn't use apneic oxygenation, and I'm hoping we do that. And they also limited their pre-ox to 10 liters. Maybe there's a shortage of oxygen there, but I'm pretty sure we can crank it up far, far more here. So I said I was going to compare these results to the paper that I did when I was at Williamson County. I've avoided talking about that paper because I don't know, I just feel kind of weird talking about something I wrote, but I'm going to do it here because I look at this RCT in India as validation of what we did in Williamson County. And just to be clear, we didn't come up with DSI either. That phrase, the concept has been around for eons in anesthesia. The phrase was coined by Dr. Weingart from MCRIT. We implemented it in a before and after setting and looked at the difference. Now, the citation for that paper is Jarvis and Gonzalez, Johns and Sager. It's called Implementation of a Clinical Bundle to Reduce Out-of-Hospital Peri-Intubation Hypoxia. It was published in Annals of Emergency Medicine in 2018. Now, this was an observational trial. Its big limitation is it was not randomized. It was a before and after study. We looked at adults who needed intubation with RSI or DSI, basically patients who are not in cardiac arrest. And our intervention was this bundle that included delayed sequence intubation. Our comparator was more traditional rapid sequence intubation. And our primary outcome, just like in the study we just talked about, was peri-intubation hypoxia. So let me go over the two bundles. So in the RSI group and the before group, we were using video laryngoscopy, just like we did in the after group. That was no difference. We pre-oxygenated to the extent that we did pre-oxygenate. We used a non-rebreather. We really didn't stress the importance of pre-oxygenation, although we told people to do it. We gave ketamine plus a paralytic. We did use apneic oxygenation, and then we would intubate. In the after group, we would use ketamine, then elevate the head of the bed, put the patient in an intersternal notch position, apply the high flow apneic oxygenation, use a BVM with a two hands, thumbs down approach at maximum oxygenation with PEEP for pre-oxygenation. We would make sure that the patient's saturation got to 94%, and then we would start a stopwatch to give them 3 minutes at above 94%. Then we would push the paralytic and do the intubation. So that was the before and after. Now, the overall results were pretty similar to what we just saw. In the before group, we had Peri-intubation hypoxia in 44% of patients. In the after group, after the DSI bundle, that dropped to 3.5%. Statistically significant, that was an absolute difference of 41%, with a confidence interval of anywhere from negative 49.5 to negative 32. We also saw a change in our first pass success rate. It went from 84.6% to 88.5%, although that was not statistically significant. Now, one of the things that we always heard about with DSI is, hey, this is going to take a long time. And it did. In general, it increased our scene times from a median of 32 minutes to a median of 42 minutes. But I'm willing to pay, this is my opinion, I'm willing to pay the cost of increased scene time if we decrease the rates of peri-intubation hypoxia, and we did that fairly significantly. Now, the thing about this paper that I'm most proud of is the graph that I'm putting up on a screen for my good friend Joseph Zalkin. This is, of course, a waterfall plot. What are my takeaways on this whole randomized control trial of DSI versus RSI? Overall, I am a believer in DSI. I think DSI is really, really good for patients who are agitated and actively interfering with your ability to pre-oxygenate them. Now, I think the benefit that they showed in this RCT, even though it is similar to the benefit that we showed, I think it is actually underestimated a little bit because of their exclusions. As you can probably tell, I didn't like their exclusions. In the hospital setting with experienced operators, I think DSI probably only has a benefit in the patients who are agitated and preventing your ability to pre-oxygenate them. In EMS, however, we very rarely have that much experience with airway management. We don't do it enough to maintain competence both in RSI and in DSI. I want to do high risk, low frequency events the same way every time. Same checklist, same thing every time to maintain competence. That is the reason that in my EMS systems, when we do DSI, we do it on everybody. I also have a hard stop at hypoxia. If the saturations drop, you abort the intubation. If you can't get the sats up, you do not intubate. We then at that point use a supraglottic. And if we need to do RSI for supraglottics, that's fine to do also. So guys, that is what I have for you today. New RCT out of India looking at DSI versus RSI in trauma patients showed a big benefit in avoiding peri-intubation hypoxia. Really consistent with the work we had done in Williamson County. Again, I'm sold. I'm a believer. I think Mikey likes it. I think it's just great stuff. We ought to use it. Guys, I hope this has been helpful, and I hope you all have a wonderful day. Take care, y'all.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.